please. And we have just begun recording, so please feel free to turn off your camera if anybody would not like to appear in the recording. So today's session is focusing on intersectional mental health stigma, frameworks and community-led evidence for understanding and action. Next slide. For anyone who is not familiar with us, we are CME, Scotland's national programme to tackle mental health, stigma and discrimination, and lived experience is at the heart of everything we do. Next slide. Our vision is for a fairer, more inclusive Scotland, free from mental health stigma and discrimination, and this means for everyone across the population. However, we recognise that our historic universal approach has excluded the most marginalised populations, and we have been doing a lot of work over the past 3 years in particular to understand more about why this is and to redress this injustice within our own work. Next slide. So today, as I said, we're looking at intersectional anti-stigma interventions. We'll be looking at the historic roots of intersectional stigma and discrimination, how these manifest in Scotland today and deepen inequalities. And we'll be looking at frameworks and community-led action at different levels to counter this. We have a wide range of contributors today. So my name is Monique and I'm the Programme Manager for the Communities and Priority Groups team at CME. And our whole team is represented today. We have Sahej, Maeve and Anna who will all be presenting. We also have our wonderful colleagues from other parts of the programme. So we have Rachel Gray from our settings team. And we also have our colleagues Lindsay from our comms team who's been helping us with tech, and Anna Da Silva who'll be hosting a separate breakout space for anybody who would appreciate a separate space for a while. So in participation today, we are going to ask you to please only participate in the chat for the first 45 minutes. We'll be having quite a lot of presentation, and then Fatima, our wonderful youth consultant, will be posing questions to our invited speakers. So we won't have space for unmuting our participants today, but we will be recording anything that people ask or comment in the chat, and we'll be using that for our next steps, which we'll explain at the end. In the second half hour of the session, we will be going into breakout rooms. So there'll be space for participation and discussion there, and we'll be having a 5-minute comfort break at 11:45. Next slide. So we've sent our Safer Spaces agreement ahead to you all, so I hope people have had a chance to have a look at that, but just to highlight a couple of things again today. So a content warning throughout our whole session today, and that's specifically about descriptions of stigma and discrimination based on race, gender, class, sexuality and disability. We won't be dwelling on traumatic experiences. We will be looking at a strengths-based approach and looking at action for change. But please be mindful and keep yourself safe. We absolutely value and welcome lived experience, but please think carefully about what you feel comfortable sharing today and what the impact might be on others, particularly in breakout spaces. Finally, I'd like to highlight that we're not here to debate if stigma is real. This is very much taken as a given in this session today. Next slide. So I would also like to highlight that we are using terminology and language that the communities and partners that we work with use themselves. We absolutely recognise the complexities around language and are committed to engaging in this important debate. We have a glossary at the end of the presentation we sent that sort of highlights our organisational understandings. And throughout where there is other terminology used, it's because of the publications we've cited, and we've included a reference list at the end as well. Next slide. So in developing our work, I wanted to highlight a couple of things around this. So we've done a huge amount of work over the last 3 years with community partners, partners in higher education across the public sector to develop content. And part of that has been really critically reflecting on things like the definitions that we use, key understandings around mental health, stigma and discrimination. And Sahej will be looking at that in more detail next. I'd also like to highlight our Anti-Stigma Arts Fund, which has been the source of the case studies we'll be looking at in our breakout discussions. And before we move on to the next slide, as part of this work, our 2 esteemed speakers who we've got joining us today have been really part of this process. So I'd like to introduce them now. So first, Dr. Carla Perez Portilla, who's a senior lecturer in anti-discrimination law at Glasgow Caledonian University. She's a keen gardener and ever-learning mother who continues to integrate academic rigour with lived experience and advocacy in her work. Thank you for joining us today. And Anil Singh Bhopal, who's the Deputy CEO of the West of Scotland Regional Equality Council, which is an equality and human rights charity based in Glasgow, supporting people from minority ethnic communities across the West of Scotland. Next slide. And finally, before I pass over to Sahej, I just want to highlight the definition of intersectionality that is underpinning the work as we develop this. And this is really that it originates in Black feminism. So the term was coined by Kimberly Crenshaw, the socio-legal scholar. However, it has much deeper roots in Black feminism and critical race studies. I'll now pass over to Sahej, who'll take us much more depth into the definitions and concepts. Thank you.
Thanks very much, and hello, everybody. As Monique has said previously, we have tried to use this critical thought on the usage of definitions, taking the intersectional approach. And it is to say that mental health stigma is not just individual persons' negative beliefs, but it is a social process that involves exclusion of groups and individuals who deviate from dominant social norms. For example, stigmatization of people experiencing a mental health problem or illness. It is also important to highlight that stigma can change over context and time, and it is not a static process. And when we talk about discrimination, which is a part of stigmatization process, is the inequitable treatment of individuals and groups. It could be intentional and very intentional as a part of policies and systems and organizations that we are a part of, and embedded in everyday practices of a well-intentioned society. Next slide. Can mental health stigma really exist in isolation with other forms of oppression, such as homophobia, sexism, and racism? The answer is no. The term that we have used here is intersectional stigma to describe that these multiple forms of stigmas that interact with each other shape inequalities and disadvantages, which cannot absolutely be understood in isolation and which interact with each other. You can also refer to the pre-session material that we sent to go more into detail. Before we move on, could I ask everybody to put in the chat, what do you think is the purpose of stigma? Can I also request next slide, please? What is the purpose of stigma and who benefits from it? Any word that comes to your mind, you can just pop in the chat. And I acknowledge that this exercise should take longer, but because we're running very short on time, could I just please ask one or two words? No one. Okay. Fear of differences. That's interesting. Bullying. Yep. Maintaining power as it is. Thank you very much. That's very good responses. Limitations. Yeah. To maintain control and power. Absolutely. Sorry about that. And thank you so much for inputs. People have already contributed. Could I please request next slide? In line with the idea of it being a social process, and to add, I would say that it has been used as a tool to subjugate, and as people have said in the chat, to maintain power. And Maeve would later talk us through the histories of oppression. But for the sake of understanding, we have divided it into three broad categories here. So the first purpose is to keep people in, to enforce social norms and values, and those who do not follow them out. Keeping people down to maintain one group's advantage over the other, and that leads to disadvantage as well. And keeping people away to avoid disease or a perceived threat, like we have historically seen with the case of HIV stigma, and now we see it in case of mental health stigma as well. Next slide. I would like to re-emphasize it again that mental health stigma is very intersectional in nature. It intersects with one identity-based prejudice, such as racism, anti-immigration sentiment, and so on. Second, stigmatized health and living conditions, such as homelessness, self-harm, and also with deeply stigmatized, marginalized identities, mental health conditions, and can be called dangerous and unpredictable. The reason I'm telling this is because to understand this nature is very important, because it presents significant barriers to support and treatment for people who are labeled hard to reach, that the term that we are very familiar with. Next slide. These are some of the lived experience accounts. I'm not going to go in detail because of the time shortage, but here the person has expressed that the assumptions made by their counselors on aspects of their identity, family, and culture undermine the need, and also undermine the need of recognizing cultural trauma. And it clearly demonstrates the need of taking an intersectional approach to support people with mental health, because it can also reinforce racialized mental health inequalities. Next slide, please. Not going on in detail with this as well, but it is important to see person as a whole person rather than just making assumptions based on their identities. Next slide, please. Here are some of the stats that highlight inequality in diagnosis, treatment, and outcomes. As I've said, May would later take us on how histories of oppression have a thread in the modern day inequalities. But looking at these examples, one is people in poverty are more likely to be diagnosed with mental illness. One, Black men are 10 times more likely to receive a diagnosis of a psychotic disorder than white men. I'm going to leave these stats over here, but we're later going to dig into that more in detail. Next slide, please. So these are some of the impacts of stigma, and people have said that most people living with mental health condition consider stigma associated with it worse than the condition itself. So these are some examples, some causes taken by Public Health Canada report. Next slide, please. There are also clear links between people experiencing stigma and discrimination and their resulting anticipation of judgmental treatment from previous experiences, which in turn leads to withdrawal from services. And this is taken from SPIS, which was a research undertaken by CME in 2022. That's me for now. I'll pass on to Fatima to explore more on this topic with our esteemed panel members today.
Thank you, Sahaj. So this question, feel free, Anil or Carla, to answer this. So why do you think intersectional approaches to understanding and addressing mental health stigma are important? If we could just unmute Carla or Anil.
I'm trying to unmute myself. So I was aware of the time, so I made a bit of a list. And to reproduce the words of Kimberly Crenshaw, it is about rescuing those falling through the cracks. The acknowledgement of mental health stigma and addressing mental health stigma shouldn't be a privilege. So it's a matter of justice. It is about unveiling distinct forms of disadvantage. It is about responding to reality as opposed to abstract binary notions. It's important also to self-assess our values and existing priorities, dominant priorities. So yeah, mental health stigma and intersectional approach allows to do all these things. And actually, I created a wee acronym for that. It's about unveil, name, address, and crucially, prevent. So what's the worth of knowing if we are not going to do anything about it, or if we are not going to prevent it? Once we know that people are 10 times more likely to something, well, logic would be prevent it, no? So UNAP. Unveil, name, address, prevent. And more than a concept, I think it is a method. It's about caring. It's about looking at reality and how to do that. I think the question is, what is this working for? You know, if you want to know who's falling through the cracks, it is difficult to know unless they tell you, but they are not going to tell you. So you can ask the question, who's this service, for example, working for? And I would like to expand on that in the breakout groups on how to go about that.
Thank you. And Anil, would you like to say anything or add on?
Yeah, no, thanks, Fatima, thanks, Carla, as well. I mean, firstly, I don't think there's any group of people in Scotland today who are completely immune from experiencing the stigma attached to discussion around mental health. So it's clear that cultural and social reckoning is needed nationally when it comes to the topic, hence the reason why so many of us are here today. But I do feel that whilst stigma is still fairly universal, there's undeniably variations in how this is experienced from community to community. When we look at the everyday work that we do at Wesrick with people from minority ethnic communities, we see firsthand the level of stigma that is attached to speaking about mental health because of a variety of reasons. And whilst I don't want to make any sweeping generalisations, and this isn't certainly the case for everyone, a lot of the time mental health problems aren't spoken about amongst the communities that we support. For many, speaking up about depression, anxiety, or low mood, for example, can be seen as being shameful or embarrassing. And for those that do feel more comfortable in speaking out, a fear of engaging with mental health services because of the worry of not being understood or having previous negative experiences of racism or discrimination can be off-putting. So all this and more acts as real barriers in preventing people from speaking about their problems or seeking help, whether that's from their friends, family, or GP. And if we take these kinds of issues into the broader picture and take the example of a young minority ethnic male from a working class background growing up in Glasgow, it's clear that someone with this particular profile type is going to naturally have more stigma attached to speaking about mental health openly, therefore heightening that risk of suffering from the negative consequences of not opening up. And each of those characteristics that are cited in that example, their age, race, gender, class, all interconnect and combine. And because of that general shared stigma around speaking about mental health attached to each of those labels, there's a real danger if we don't recognise things in an intersectional way. So just touching on what Sedge spoke about there, sadly, the purpose of stigma in our society in this age is still winning, in the sense that preferred social norms and values are still being reinforced in various different ways.
Thank you so much. Next slide, and I'll pass to, is it Maeve?
I will jump in here. Sorry, I was expecting it to be Monique and it threw me right off. Good morning, everyone. Thanks very much, Fatima. So I want to talk briefly about why bringing in historical context has been so important to this approach. I'm not going to go through these slides line by line because, as we keep emphasising, we've got lots to get through. We don't have lots of time, but we did share a short video that Rachel created, which actually goes into much more detail on this. So I would really urge everybody to watch that if you haven't already, if you're interested in this. So as we develop this strand of work, understanding the historical context that's brought us to this point has been absolutely crucial. But there are significant ethical choices and responsibilities about how best to present this. We want to explain the reality of both past and present injustice, but make sure that we're very clear on the rationale for sharing what are often deeply painful and traumatic experiences. So colonialism, racism, and other supremacist beliefs infiltrated the scientific establishment in the 19th and 20th century, including the emerging field of psychiatry through eugenics movements, which claimed one group's superiority over others under pseudoscientific labels. And that in turn created the pursuit of physical and mental, quote unquote, normality. Can we have the next slide, please? This history really underlines how crucial the intersectional approach is when we look back to see how certain identities and experiences have been pathologized along racial, gendered, sexual, ableist, socioeconomic lines, upholding and reinforcing societal norms. Next slide. We can take, for example, the way that schizophrenia in the 1960s became understood as a condition primarily affecting young Black men, and exemplified by the very understandable anger and mistrust that was perceived in civil rights activists. We've already heard from Sahej about the present day inequalities that persist for example, racialized communities within health settings. And to understand the present day discrimination, we need to understand these deeply entrenched stereotypes and preconceptions that have led us to this point. However, it is really important to remember that the stories that we share from this history of women diagnosed with hysteria, of enslaved people escaping plantations with drapetomania, of LGBT plus people pathologized as mentally ill, are also a collective history of resistance and a brave refusal to conform to brutal societal norms and oppression imposed by powerful elites. Later, Anna will have more to say about the huge significance of social movements and activists in changing laws and protecting rights for marginalised people by stigmatising systems. For now, that's an incredibly quick overview. But as I say, please check out Rachel's recording that you should all have for a much more detailed look at this. And I'll pass back to Fatima, I think, for our second panel question.
Thank you, Maeve. So the second question for our panel is, why is an historic analysis important to understanding and challenging intersectional mental health stigma? Anil, would you like to go?
Yeah, thank you, Fatima. I think it's essential because, as Maeve just touched on there, so much has gone before us that it's unfortunately led to the level of stigmas experienced by minoritized communities today, whether that's been through colonialism, which relied on the shared belief that certain groups are inherently morally, physically, and intellectually inferior, or through eugenics, which again, just to use the definition on Maeve's screen there, provided the pseudo-scientific rationale for colonial violence and the idea of the socially undesirable, or through scientific racism, which was embraced by the psychiatric establishment of the 19th and early 20th century. So simply, we can't ignore how the evils of our past continue to shape the problems of our present, and we can only challenge these problems by addressing them head on and learning from them. I actually read something yesterday from Rennie Edo Lodge's book, which was released around the time of the first lockdown. It's called Why I'm No Longer Talking to White People About Race. And I found a particular excerpt especially fascinating. It sort of reinforces that point of how those evils of the 16th to 20th century, for example, which were promoted through colonialism, eugenics, scientific racism, and other systems of supremacy and power, continue to harm minority ethnic people in the United Kingdom today. So I thought it might be helpful to share a bit from that excerpt, which hopefully helps to provide a bit more context to what I'm talking about, what Maeve was talking about, and what Sedge was speaking about earlier. So this is taken from page 73 of the book, and Rennie explains that a 2003 NHS England report confirmed that there is a uniformity of findings that people of African and African Caribbean backgrounds are more at risk than any other ethnic group in England to be admitted to psychiatric hospitals under the compulsory powers of the Mental Health Act. So that's being sanctioned against your will. In the same year, 2003, an inquiry into the death of David Bennett, a black man who died in a psychiatric unit, added black people tend to receive higher doses of antipsychotic medication than white people with similar health problems. They are generally regarded by mental health staff as more aggressive, more alarming, more dangerous, and more difficult to treat. And instead of being discharged back into the community, they're more likely to remain as long-term inpatients. So I think on the basis of that paragraph alone, a pretty in-depth historic analysis on understanding and challenging intersectional mental health stigma could be made in itself. And that just goes to demonstrate the level of what is needed out there in terms of proper understanding and awareness around this subject matter.
Thank you so much, Anil. Carla, would you like to say something?
Yes, historic analysis is essential. In fact, as a teacher, I tend to use a little formula for any researcher for understanding of any issue. So what is the problem? How did we get there? That's where we start digging, because nothing comes out of the blue. And then what are we going to do about it? Yes, it's essential to understanding issues. And talking about racism. In a blog recently, I wrote about institutional racism. It cannot be understood outside the colonial, imperial past. It simply doesn't make sense. We cannot understand things unless we know their history. And a young person told me, well, excuse the parallel, but he said, I think we are living with the hangover of colonialism. And I told him, well, I think it's more like the head of the dog, because we keep doing things. We keep reproducing colonial values. And for example, just the fact that has been acknowledged earlier that intersectional stigma is not until recently, relatively recently, a priority, is a symptom of that happens in many, many institutions. And some people would say, well, but if it happened in the past, it's in the past, isn't it? It was long time ago, and many people resist that. So again, another parallel, I hope you will excuse, but I think it is really helpful. Racism is like a childhood trauma. It may have happened many years ago through colonialism and imperialism, but it just doesn't go away. Like any other trauma, it needs to be acknowledged, it needs to be addressed. Otherwise, we will keep on bringing it back through attitudes, behaviors, prioritizing or not. So, yes, understanding the history of issues is crucial in order to take action, because nothing just stays in the past. It is part of our makeup.
Thank you so much, Anna. Sorry, Carla. Can we just pass for the next slide for Anna? We're just conscious about the time. Thank you.
Yes, thank you very much, Fatima, and thank you to Anil and Carla for so eloquently putting it there. And just to reiterate, I guess, what you've just said, like, to really understand an intersectional approach and intersectional principles, we really do need to look to history. We need to understand power and oppression. We need to understand how historic harms and legacies are still playing out today. But as Maeve mentioned, it's also really, really important that we also look at community resistance as well. And really a sort of move away from emphasizing community deficits is a really key part of an intersectional approach as well. So instead, focusing on community strength. So understanding factors that support like collective action, cohesion, and resistance are a key part of this as well. So we know throughout history, change has really been made by communities coming together around a shared cause. And social movements have long been a tool for marginalised people to be able to resist and to challenge oppression and inequality. And grassroots movements have really sort of laid the foundation for changes to damaging ideologies, to legislation, as well as to institutional procedures and treatment. And when we go through these examples together, we'll also see them sort of highlight the need for them still today. We really sort of wanted to just highlight a few of the many changes that have been made through community power, and also kind of reflect on what it is that makes community action successful and what kind of, I guess, evidence we can take into an anti-stigma evidence base as well, because we really feel that the links are really strong between the two. So we'll go on to talk about that as well. So I'm not going to talk through every example on the slide because, as we are aware, time is very tight this morning. But just we'll start with this first one. So the very first union of mental patients in the UK, I believe, was founded in Hartwood Hospital in North Lanarkshire between 1971 and 1972. So it's a really strong example of where a group of people whose power had been very much stripped away from them managed to come together in community to agitate for change. Somewhere, like I say, where very little power had been given to them and power had been taken away from them. As part of the gay rights and sort of civil movements in the 60s and 70s, there was like concerted action to try and remove homosexuality from the DSM, which is a diagnostic, let me read this, Diagnostic and Statistical Manual of Mental Disorders, where it was there as a mental illness. So it was a kind of years-long effort around declassification, and it culminated in 1972 when a gay psychiatrist attended the American Psychiatrist Association's annual general conference and spoke on a panel of lived experience there about his experience. And then again, more LGBT plus voices were heard the following year. And then the board at APA voted to remove it from the DSM. So that's again sort of lived experience, direct action, making actual change in terms of legislation. Next slide, please. Thank you. Here's a couple of more recent examples. So prior to 2019, transgender identities were also in the DSM, but actually in 2019, trans advocacy groups managed to get that changed via the WHO. Then in 2021 and 2022, there were two sort of historic, quite historic apologies made by the APA and the Royal College of Psychiatrists, where they made public apologies for institutional racism. And that was really through the Black Lives Matter movement and all the amazing work that has been carried out by them. It's a really important acknowledgement, obviously, but we do also know that there is still a huge way to go in terms of removing some of the baked-in racism that is really inherent in so many of our systems. Can I have the next slide, please? So how do we really quantify what works when it comes to community action? And how does that impact our evidence base around anti-stigma work? Like I already mentioned, it feels like for us, the links are quite clear in terms of a community approach rooted in grassroots and our anti-stigma approach. And this slide highlights some of the key elements from the global evidence base around an anti-stigma approach. And I think just through reading through it, you can see how that really does come through a community action approach. So for us, the links are incredibly clear. We know that the act of coming together within communities really builds resistance. And this can really lead to a sort of a power change, as it were. So communities being able to use their power to really agitate for and achieve change. And so it's so important that we learn from this with our approach and see how we can adapt that into approaches. I'm going to pass back over to Fatima and the panel, who are going to talk a little bit more about how it's possible to do that now. Thanks, Fatima.
Yeah, Anna. So this question is specifically for Anil. So the grassroots organizations are generally peopled by the marginalized communities they seek to serve. How might this lived experience, belonging, and integral care be replicated by workforces and institutions?
Yeah, thank you very much, Fatima. And obviously at WESREC, we are led by people with lived experience of the issues faced by many of our service users. So that works well internally, but we also do a lot of external work at WESREC in terms of offering support and guidance to organisations across the public and private sectors in relation to how they can make basic changes to improve inclusivity. So I thought it might help for me to give a few core examples of what we recommend in that vein, which hopefully answers your question there. So something that we recommend in terms of helping to create a sense of safety and comfort for diverse staff and users in spaces is having a think about developing an anti-discrimination manifesto or statement, which can be shared in your spaces, whether that's online or physical or both. I used to do a bit of work in Stirling with an environmental charity called Recyclebike, and they had a really strong and simple anti-discrimination statement at the front of their premises, and that helped to set a welcoming tone from the get-go as soon as you entered into the venue. And it simply read, Recyclebike commits to providing equality of services and care to everyone, regardless of people's age, disability, gender identity, race, religion or belief, or sexual orientation. We also recommend that organisations create reading and resources list, which focuses on anti-racism more specifically because of the nature of our work, but that can be widened out to include more broader equality issues. And that sort of list can be used internally to educate staff, volunteers and board members. So again, we did a bit of work with an organisation called the Anti-Racist Educator, who are a collective of educational stakeholders working towards building a fairer education system in Scotland. And they've produced a really wide-ranging reading list, which will definitely be worth checking out and seeing whether you can maybe mirror within your own organisations. We also recommend that institutions create safe spaces for minoritised people to discuss issues that may directly affect them, whether that's racism or discrimination or other issues. And this can also then have the knock-on effect of helping the people that you are actually seeking to support in the community. So developing something like an in-house forum for staff, board and volunteers with lived experience and also allies where relevant issues are discussed can help colleagues to work together to find common solutions for the benefit of the communities that you're working with. And also, just before I finish up, bring in grassroots experience to support the work that you're doing. There's so much lived experience, knowledge and awareness within the third sector that I think still being underutilised, and that could make a bigger impact on public life and the communities that you're supported if it is better supported and I guess promoted by the public sector. But whilst that sort of offer is there and people should be making use of the third sector, the work that we do shouldn't be taken for granted at the same time. I'm sure you're all aware we're under-resourced and overworked. So I wouldn't see it as greedy, essentially, when we're asking for a bit of financial support to carry out work. It's just becoming more and more difficult and more of a necessity in order for us to keep our heads above water. Also, sort of the work that we do externally when we talk about anti-racism, for example, takes a physical and emotional tool. So I think it's only reasonable that, you know, remuneration in some cases is offered. But hope that helps answer your question there, Fatima.
Thank you so much, Anil, for all the recommendations there. I'm sure it's been very valuable to listen to. I'll just pass over to Rachel.
Thank you, Fatima. So I'm gonna take us through frameworks for understanding and action. So in order to locate and take action on stigma and discrimination, and you'll have heard the depths and the embeddedness of all of that history and legacy, we need to then take that information and to break that down and to understand that and then to take action. So we use some guiding principles and frameworks to allow us to do that, and we support organisations to do that. So there are 4 key principles that Steve Wright defines. And so these are intersectional stigma reduction intervention principles. So the first is about recognising and naming the systems of power that intersect with each other and have a huge impact on individuals' experiences and fuel stigma against them. Number 2, that we aim to dismantle systems of power and oppression and to mitigate the harm that they do, and to ensure.
Rachel, I am afraid you're on mute. Sorry.
No, for the whole time. Just there, right? Okay. Thank you, Serge. Can you hear me now? Can you hear me now? Yes, right, okay. So number 3, third principle being ensuring community leadership and meaningful engagement. And number 4, supporting collective action, cohesion and resistance to address the intersecting axis of inequalities. So how do we do that then? So we have drawn from numerous pieces of evidence. Really key piece for us has been Carla's work, Carla's research around prejudice and discrimination, and that work has given us this, what we call the SKIP framework. So SKIP refers to the structural, the cultural, the institutional, and the personal. So this demonstrates that stigma and discrimination is operating at multiple levels within our societies, and it involves really complex social processes. So we're also guided, and this is an adaptive version of the SCIP, and we've also pulled from research that is guided by the social determinants of health. So it's a kind of robust framework that is looking at both and pulling together research that is from public health around social determinants of health, and also key research that attends to how prejudice happens, how it becomes embedded, and what we need to pay attention to dislodge it or dismantle it. So this framework that we use allows us to target interventions at multiple strategic levels. So very briefly, at the structural level, we can consider this as being both external to an organisation, such as the live political ideologies that are happening at that period of time. Who is in power within government? Who is holding the power, and what are they saying in terms of ideologies around different peoples and their identities, also the policies and the legislation, and these overall things externally to our institution then influence what happens within our institutions, because they determine whether and how they will be funded. At the structural level within an institution, we're talking about leadership and governance. So this is the place where setting policies, setting practices, and resource allocation starts to become embedded within the institution. And at the institutional level, that's where we can see the enactment of the policies, the enactment of the practices that may or may not benefit us as individuals with intersectional, marginalised identities. At a cultural level, we're talking about damaging ideologies filtering down from government, but also from other places such as media, and these ideologies become labelling, and they start to embed themselves in our interpersonal relationships with others within schools, within how we communicate with each other and between communities of people. And then finally, at the personal level, we're really talking about how the stigma and the damaging ideologies then become embodied by people. So how people with those stigmatized identities, mental health conditions, and or stigmatized coping mechanisms internalize these deep-rooted negative societal beliefs about themselves, and how that then has an impact on their mental health. And I think that's me, Fatima. Thank you.
Thanks, Rachel. So this question, which is our final question for today for the panel, is for Carla. So why is SCIP an essential framework for understanding and action?
Oh, well, first of all, thank you for the acknowledgement, although I must say this is an analysis that I learned back in 2004 from Andrew Johnson and Stuart Ainsworth from the University of Strathclyde. I have used it for many years. I have further developed it, but it comes from them and from many other authors. In fact, it is simply really a way of explaining oppression as systemic, as opposed to coming from only one source. Now, it is simply really about unpacking. It is about thinking things through. It's as simple as that. It's about deconstructing. And why is that helpful? Because once we know how an issue developed and all the levels at stake, we can allocate responsibilities and we can see what is in our hands. So it is a plan for action. So once you understand that problem and all its layers, you can say, oh, this needs to change, this needs to change, this needs to change. Now, who can change it? Well, this will need to be changed by legislators. This will need to be changed by leaders. This will need to be changed by the school curricula and so on. But what is a risk for that, or barriers to that, would be an approach in which when people wash their hands, no? Oh, well, yes, we can acknowledge that there is institutional racism here, but that is embedded in culture. So what can we do? No, yes, there are many things institutions and third sector organizations can do to change other levels that apparently are not fully in their hands. Yes, indeed, they will not be able to change history or culture and the curricula and the media, etc., but they can challenge themselves inside. They can change their culture inside. And others can say, well, yeah, but we cannot change the law, can we? I mean, we can acknowledge that there might be certain laws that are not good enough or that they could be improved, but that's not in our hands, is it? Well, the law is dynamic. And most of equality rights, if not all, are the result of collective action. And that takes us back to Anna's slides. If you dig into the history of any of the rights that we have, they have never been the gift of an enlightened ruler. They have always been fought for. You know, I was just recently looking at some developments. For example, Jack's Law is about bereavement rights for workers. That's from 2020. And the name gives you a clue. It was the parents of Jack who died that fought for it. If you look at Martha's Rule, again from 2021, it was fought by the parents of Martha. And that is a right that families have to request urgent review of the care of their child. The Online Safety Act, it was due to the fight of the parents of Molly Russell, who died by suicide. And it has to do with what was happening in social media. So you see, it has been people fighting for it. So yes, we of course can change the law. Another barrier, if you like, could be the lack of power. No, I mean, we at a personal level might want to change our institution. We may want to call out the lack of leadership and so on, and say, yes, go do it. Yeah, really? I mean, anybody that has done any work in EDI would say that's not that. It's not an easy thing to do. Call it out, no? Because the political will, the leadership is essential for any change in an organization, be it small or big. And yes, it would be easy to say, just call it out, you know, be strong. But people are not going to do that realistically because people fear losing their jobs and so on. But again, this takes us back to Anna's slides and look at the history of social movements. Get together with those that are like-minded, form coalitions, networks. This is some work that we have had on the pipeline for years now, and it is about support for those, for example, doing EDI work or working on intersectional approaches to mental health stigma, or people working on anti-racism, to come together for that support. There is a strength in doing things together in collective action for the things that we cannot do alone because of powerlessness, or as Anil was saying, because it is just so draining. We need to come and talk to others that think and experience the same issue so that we can come up with solutions together. So yes, the SCIP analysis is a tool for understanding, it's a tool for action. It helps to allocate responsibilities. It helps to know what is in our hands and what is not, but that doesn't mean that we cannot push for those changes. Sometimes it will be easier than others. When it is not, go to others, rely on a support network to do things together. I'll leave it there, Fatima. Thank you.
Thank you so much, Carla. I think we're now going on a break for 5 minutes. We are running a bit of time, so I think we'll just leave it we're here for now. 5-minute break and
Thank you, Fatima. I'll just jump in quickly. So yes, we are only running 5 minutes behind, which is unbelievable. Thank you so much for all your incredible contributions to both of our invited speakers and to my wonderful colleagues as well, and Fatima for posing the questions so eloquently. If everyone could just take a quick comfort break, and we will try and aim to be back here no later than 11:55, please, to go into the breakout discussions. If you are a little bit later, you may just find yourself in a new room, but Anna will be introducing our breakouts shortly. See you all soon.